Hello and welcome to my YouTube channel. Today we will be discussing one very important topic which I would find it would be useful for postgraduate residents as well as for MBBS students who would be appearing for the surgery exam. And the topic is Barrett's esophagus. Let's delve deeper into what exactly is Barrett's esophagus. Let's try to understand its pathophysiology and what are the recent modalities of treatment of Barrett's esophagus. Just to find out what are the exact things, the statistical wise, we have 10 to 15% of chronic gastroesophageal reflux disease patients who go on to develop Barrett's esophagus. The progression from Barrett's esophagus to esophageal adenocarcinoma EAC is approximately 0.2 to 0.5% per year according to different literature studies. And the rise in esophageal adenocarcinoma beyond 50 years is almost 6 to 10 times in a patient who has got Barrett's esophagus than in a patient whose mucosa is normal. So with this background, let's go deeper into what exactly is Barrett's esophagus and try to understand its risk factors and epidemiology. So what is the standard? What exactly is Barrett's esophagus? It's a replacement of a normal distal esophageal stratified squamous epithelium. The normal distal stratified squamous epithelium gets replaced by columnar epithelium, but the most important thing is that they should have goblet cells, and then it would be known as intestinal metaplasia. And why this would occur, why this replacement from stratified squamous to a columnar with goblet cells would occur? Because it is an adaptive response to a chronic acid or a bile reflux, especially in the setting of gastroesophageal reflux disease. So what are the key risk factors for development of Barrett's esophagus? The number one is the chronic gastroesophageal reflux disease present for more than 5 years. That is one of the most important risk factor. Then we have a age criteria where the patient's age is more than 50 years. Male sex, if you see the ethnicity, white ethnicity, central obesity, and patient who are chronic smokers are also at risk of development of Barrett's esophagus. And another important risk factor is family history of Barrett's esophagus or esophageal adenocarcinoma would predispose the patient to the development of Barrett's esophagus as compared to a normal population. So if you see the sequence of progression from a normal squamous, stratified squamous epithelium, when in a setting of chronic gastroesophageal reflux disease, this would over a period of time, say more than 5 years, would lead to development of esophagitis. This esophagitis gradually gets transformed into Barrett's esophagus. And this Barrett's esophagus are at risk of going into. So Barrett's esophagus is a metaplasia. Now, what we call intestinal metaplasia. Now, it can go on to develop into dysplasia. That means the dysplastic feature starts to appear in the Barrett's esophagus columnar epithelium. And then it can start from a low grade dysplasia and then it can go on over a period of years to develop a high grade dysplasia. And when a patient on histology shows high grade dysplasia, then these patients are at risk of subsequently developing esophageal adenocarcinoma or EAC for short. We have already seen that 10 to 15% of chronic GERD patients are at risk of development of Barrett's esophagus, and the annual progression from dysplasia to esophageal adenocarcinoma is at the rate of 0.2 to 0.5% per year. Now, what is just to going into more detail about pathophysiology, the chronic reflux injury because of gastroesophageal reflux disease of acid as well as bile. Generally, it is a mixed reflux. It damages the squamous mucosa of the distal esophagus, especially near the gastroesophageal junction. Over a period of time, as a protective mechanism, this injured squamous epithelium gets replaced by a columnar epithelium with goblet cells, which is nothing but an adaptive, more acid resistant phenotype, what is known as intestinal metaplasia. So this columnar epithelium with goblet cells are more resistant to acid as compared to a stratified squamous epithelium. Now, over a period of time, the molecular drivers comes into play where stem cell reprogramming occurs. P53 mutation may occur, and this would lead to uh, further further amplifying the ongoing injury. And finally, this instability, the genomic instability, would drive a simple indolent metaplasia to a low grade and then finally a high grade dysplasia and leading to a adenocarcinoma. This sequence from a low grade to a high grade dysplasia to adenocarcinoma may take some years to develop. So this is a basic, you can say, the progression, the pathophysiology, why it occurs, and how the Barrett's esophagus develops. Remember that this metaplasia in Barrett's esophagus is known as intestinal type. That means it contains goblet cells which are Alcian blue positive. There is another type of columnar mucosa which is a cardiac type which has no goblet mucosa. That if it is present, then it would not be labeled as Barrett's esophagus. So this is one of the very important criteria. Now let's go into the diagnostic and different types of classification systems used for Barrett's esophagus. So what are the diagnostic criteria for Barrett's esophagus? The most important diagnostic criteria is endoscopic suspicion of Barrett's esophagus. And what are the endoscopic suspicion features or red flags? Salmon colored mucosa extending more than or equal to 1 centimeter proximal to gastroesophageal junction. That means during endoscope, if a salmon colored, pinkish colored mucosa is seen extending more than or equal to 1 centimeter above the gastroesophageal junction, then that would be one of the important diagnostic criteria of Barrett's esophagus. The second obvious diagnostic criteria would be a histological confirmation. When you take a biopsy from that mucosa, which appears to be suspicious on endoscopy, then on histology, you can clearly see the intestinal metaplasia with goblet cells on biopsy. Number three, always follow the Seattle protocol. What is a Seattle protocol in Barrett's esophagus? It's nothing but four quadrant biopsies every 1 to 2 centimeter of the segment, the Barrett's esophagus segment. So that means you take a four quadrant biopsy from the four quadrants every 1 to 2 centimeters of the suspected Barrett's esophagus segment. This way of taking a endoscopic biopsy in a suspected case of Barrett's esophagus goes by the name of Seattle protocol. And also take a targeted biopsy of any visible nodule or any irregularity or any other unusual lesion. So these are the four important diagnostic criteria, or you can say a workup for a patient of Barrett's esophagus. Then we have a classification system. And what is a typical or most useful classification system which is used endoscopically? That is known as Prague CNM classification. Prague, that's the place in Czechoslovakia where this first classification system was devised. So we have a Prague CNM. C stands for circumferential extent. That means how much of the Barrett suspected mucosa wraps around the circumference of the esophagus. So circumferential extent above the gastroesophageal junction in centimeters, and M stands for maximum extent again in centimeter above the gastroesophageal junction, and this also include what is known as tongues. So suppose on endoscopy, if it is reported C2M5, that means the circumference of the lesion is 2 centimeters and the maximum extent above the gastroesophageal junction is 5 centimeters. So this would be labeled as C2M5. And this, what is the advantage of using this Prague CNM classification? This would standardize the endoscopic reporting across different institutes and different countries. Now, coming to what are the dysplasia grading, we have already seen. First, there would be no dysplasia. Then we have an indefinite type of dysplasia, which is more of a gray zone. Then we have a low grade dysplasia, and ultimately a high grade dysplasia, which is at risk of going into developing esophageal adenocarcinoma. Now, what are the recent management protocols for Barrett's esophagus after having understood the pathophysiology and diagnostic and classification features? So first we have to give a risk stratified surveillance of such patients who have Barrett's esophagus. So we have number one, risk stratified surveillance, number one criteria. If there is no dysplasia and it is short segment, no dysplasia and short segment. So short segment is defined as generally uh, about 1 centimeter or so. So if there are no dysplasia on histology and it's a short segment, then you have to do a 3 to 5 yearly surveillance protocols in such a patient. On the other hand, if we have a no dysplasia, but it is a long segment, that is the long segment is defined as equal to or more than 3 centimeters, then you have to do a 3 yearly surveillance protocol including endoscopy for such patients. If we are having indefinite dysplasia, that means you cannot define whether the dysplasia is present or not, then you have to do a repeat proton pump inhibitor therapy with scope in 6 months. If the patient exhibits low grade dysplasia, if the patient exhibits low grade dysplasia, then you have to do a surveillance every 12 months. Should be done. Surveillance every 12 months should be done. And if it is a high grade dysplasia, or even a intestinal metaplastic features, then you do a in some sort of endoscopic eradication therapy should be done, what is known as EET. EET. So endoscopic eradication therapy would be applied to a patient who has got some dysplastic features, whether a low grade dysplasia or a high grade dysplasia. In other patients who has no dysplastic features, then only surveillance would be required depending on the segment. Whereas in a patient who has got dysplasia, whether low grade or high grade, you would require some sort of endoscopic eradication therapy because these patients are at risk of development of esophageal endoadenocarcinoma. So here the dysplasia is a key. Presence of dysplasia would shift the management more towards eradication therapy. Now let's go into details about what exactly are the two types of or three types of endoscopic eradication therapies we know. We have one, radio frequency ablation, which is a first line therapy for a flat dysplastic Barrett's esophagus. This would eradicate this metaplastic features in almost 80 to 90% of cases. So when you have a very flat dysplasia, a very flat lesion with dysplasia, then in such cases, the first line of therapy would be radio frequency ablation. The second endoscopic eradication therapy is EMR, endoscopic mucosal resection. And the second one is endoscopic submucosal dissection. Now coming to endoscopic mucosal resection or EMR, these are basically used where through the endoscope the mucosa is resected, which shows the dysplastic features. So ideally, it is used for lesions which are flat lesions and which are 1 to 2 centimeters in uh, maximum extent, 1 to 2 centimeters. In such cases, endoscopic mucosal resection would be favorable. However, if the lesion is nodular or if the lesion extends to more than 3 centimeters in maximum dimensions, then endoscopic submucosal dissection is done, where the mucosa is shaved off from submucosa above. So we have EMR and then we have ESD, depending on the type of the lesion, the size of the lesion, and whether it is a flat or a nodular lesion. So these are the two important types of endoscopic eradication therapies after radiofrequency ablation. And then we can also do a cryoablation therapy where liquid nitrogen or a carbon dioxide spray can be used, which can be used as an alternative therapy in case where the radiofrequency ablation fails or if there are large segments of Barrett's esophagus. So recommended for high grade dysplasia and low grade dysplasia, we have already seen the recent guidelines of 2024 says that endoscopic eradication therapy is now favored over surveillance alone. Always give a high dose proton pump inhibitors post procedure. This would aid squamous regeneration. Just to now recapitulate what we have just seen in a few important points. What exactly is Barrett's esophagus? From squamous to columnar metaplasia with goblet cells seen in the distal esophagus secondary to chronic gastroesophageal reflux disease. The sequence is from metaplasia to low grade to high grade dysplasia and ultimately adenocarcinoma. Diagnosis is done by endoscopy. Seattle protocol biopsies, where there's a 4-quadrant biopsy, should be done every 1 to 2 centimeter of Barrett's esophagus segment. Report extent via Prague CNN classification. Surveillance should be risk stratified 3 to 5 yearly for no dysplasia to 6 to 12 months for low grade dysplasia as per the newer protocol. Treatment is always endoscopic eradication therapy, either a RFA combined with EMR, that is endoscopic mucosal resection, or ESD or endoscopic submucosal dissection is now the first line therapy for low grade dysplasia and high grade dysplasia, replacing initially what used to be done was wait and watch. And red flag is any visible nodular lesion always should do a EMR or a ESD. So with this, we have come to this very important topic. I hope you have understood the pathophysiology and its features. If you have liked my presentation, please subscribe to my video. I'll keep on coming with very important topics in detail, especially useful for the PG residents and MBBS students and students who are appearing for NEET, PLAB and USMLE. Thank you very much for your time and thank you for watching my channel.